So good evening, dear friends. On behalf of Association of Physicians of Ahmedabad and Noble Gastro Hospital, Ahmedabad, I welcome you all to 21st Clinic of Advanced Gastro Summit 2020 and now 2021. So today we have a very important topic, and Dr. Pankaj Desai from Surat will be delivering and educating us on role of GI endoscopy in treating and curing early GI cancer. Good evening, dear friends. On behalf of Association of Physicians of Ahmedabad and Noble Gastro Hospital, Ahmedabad, I welcome you all to 21st Clinic of Advanced Gastro Summit 2020 and now 2021. So today we have a very important topic, and Dr. Pankaj Desai from Surat will be delivering and educating us on role of GI endoscopy in treating and curing early GI cancer. Good evening, dear friends. On behalf of Association of Physicians of Ahmedabad and Noble Gastro Hospital, Ahmedabad, I welcome you all to 21st Clinic of Advanced Gastro Summit 2020 and now 2021. So today we have a very important topic, and educating us on role of GI endoscopy in treating and curing early GI cancer. Good evening, dear friends. On behalf of Association of Physicians of Ahmedabad and Noble Gastro Hospital, Ahmedabad, I welcome you all to 21st Clinic of Advanced Gastro Summit 2020 and now 2021. So today we have a very important topic, and educating us on role of GI endoscopy in treating and curing early GI cancer. Good evening, dear friends. On behalf of Mr. Ram.
Then can you please look into that? There is a technical issue in that.
Yeah, you can start. Mr. Ram. Mr. Ram, are we live? Yeah, you can start. Okay.
Sir.
So today we have Dr. Pankaj Desai with us, who will be discussing.
Sir, probably one of us is on two systems, sir, mobile as well as laptop, sir.
Okay.
Logged in, sir.
Someone check, please.
So
are we live?
Sir, we are live, sir, but probably within the faculty, sir, we are on two places, sir, live also and Zoom also, sir.
Today we have Dr. Pankaj Desai, who will be discussing.
Sir, probably one of us is on two systems, sir, mobile as well as laptop, sir.
Okay.
Logged in, sir.
Someone check, please.
So
are we live?
Sir, we are live, sir, but probably within the places, sir, live also and Zoom also, sir.
Today we have Dr. Pankaj Desai, who will be.
रावल सर, रावल सर आप AGS 2 से लॉग ऑफ कर लीजिए सर. आप सिर्फ जूम पे रहिए सर.
Is that okay? Mr. Ram?
Yes sir, I think it's okay now sir.
Yeah. So
it is okay now.
Yes. So sorry for the technical error. I welcome Dr. Pankaj Desai today. Before that, I would like to introduce our mentor and teacher, Dr. K.K. Rawal, who is a very senior gastroenterologist experienced in third space endoscopy as well as ESD and EMR. It's an honor that he accepted my invitation to moderate this session today. So I would request you to introduce our chairpersons, and then Dr. Pankaj Desai sir will start the talk.
Thank you, Yogesh. Must to thank you for this nice academic activity. In this Corona time, we can't attend any conference, but this is a nice, we can attend at the comfort of our home also. So today's chairpersons are Dr. Abhishek Kakru, who is a very eminent medical oncologist from Ahmedabad, and another one, Dr. Murtuja Lakshmidhar, who is a very senior surgical oncologist from Ahmedabad. Now I hand over the proceedings to the chairpersons. They can start, please.
I would like to introduce Dr. Pankaj Desai sir. He is an endoscopic surgeon from Surat Institute of Digestive Sciences, Surat. He expertises in endoscopic ultrasound, third space endoscopy, and endoscopic mucosal resection and dissection. He has been invited as a speaker for same topic in national and international meetings. It is an honor he accepted our invitation. So please, you may start your talk now.
Uh, Thank you, Yogesh, for this invitation, and I'll just start my screen sharing. Are you seeing my
Yes.
slides?
Yes,
Yes.
sir, we can see it, sir.
Okay. Right. So the topic which Yogesh has given me is early GI malignancies. Can endoscopy do something about it? So I think I have given the answer in my topic, that is endoscopic resection. And the two main aspects of the endoscopic resection that we are seeing is ESD and EMR. What is ESD and what is EMR, that we will come and show you later. ESD or any endoscopic resection for that matter is applicable to for those GI neoplasms that are limited to the mucosa or superficial submucosa, and those that have minimal risk of nodal metastasis. So we can resect out any tumor which we see in the superficial layers of the gut wall. And what are these superficial layers? They are the mucosal layer, which is divided into M1, M2, and M3, and the submucosal layer, which is just below the muscularis mucosa, and that is SM1 layer, SM2 layer, and SM3 layer. So if any tumor is there within these two layers, we can resect it out endoscopically. And for resecting out, we have to have a morphological classification of the lesion, and we have to have a T staging. So this small diagram here shows you a morphological classification, which is a Paris classification, and it will show you whether the tumor is pedunculated, whether it is sessile, whether it is flat, or whether it is depressed, and whether it is excavated. If the lesion is excavated, it means it is having a deeper infiltration. So depending on this, we decide the T staging, whether it is T1, T1S in situ, or T1, which is the superficial layer, or whether it is a deeper invasion. So once we decide this, we can classify and we can start the thinking about the resection. And most important for deciding whether any GI cancer is resectable or not, we have to assess the depth of the lesion, which is the most important. Then we have to know the lymphovascular infiltration, and the lymphovascular plexus is in the SM2 layer of the diagram which I showed you. As the penetration of the lesions increase, the risk of lymph node metastasis increases, that we all know. And if the lesion is only mucosal, it is a 2.7% risk of lymph node metastasis, while if the submucosa is invaded, it is a 18.6% chance of lymph node metastasis. So what types of endoscopic resection do we do? First is a mucosectomy, that is if there is a very small lesion like a small polyp, we can just resect out and remove that lesion in total, that is mucosectomy. But what we will be discussing today is ESD, that is endoscopic submucosal dissection. And if it is only mucosal or very small lesion, we do an EMR, that is endoscopic mucosal resection. The mucosal resection goes through mid or deep submucosa. It provides tissue for accurate histopathological staging, and it is both diagnostic and it is potentially therapeutic. So, what would be the indications and in which cases would we do an endoscopic resection of a tumor? So, broadly speaking, it would be superficial mucosal lesions in the upper GI and the colon, any benign lesions that we see in the upper GI or the colon, Barrett's esophagus with dysplasia, any pre-malignant lesion, polyp with intramucosal carcinoma, early GI cancers, and some expanding indications. These are in broad the indications which we see in esophagus, stomach, and colorectal, but I will go into a little detail to tell all of you that endoscopy, whenever we are doing, it is not just seeing, the mucosa is little red, mucosa is appearing little shaky or little irregular, but we have to be very careful that we do not miss a lesion. And for that, I have classified and I will show you in which circumstances do we as endoscopists would barge upon doing an endoscopic resection. For esophagus, we have the indications depending on the depth of invasion. So if it is in the mucosa M1 or M2, and if it is in the M3 or SM1, but the depth of invasion is less than 200 microns, if the circumference is 2 to 3 centimeters or maybe 3 to 4 centimeters, and Paris, which is, it is either a superficial, it is not deep invading, or a elevated lesion, we would do a mucosal resection or an endoscopic resection. So whenever we are examining the esophagus, what we would see in simple words, we would see the esophagus, we would see if there is any red area or any abnormal area which is there, and then we switch on a mode which is called NBI or a narrow band imaging, which only filters blue and green light, and we will see the superficial lesion as a dark spot like this. Once we see this, the second stage, whenever we are doing an endoscopy, all endoscopy should know that to detect any lesion in esophagus, we have to give less air. And the second point, whenever you are having a stomach, you have to give more air. You see this picture on the left. You are seeing a stomach which appears absolutely normal. So if you are doing a fast, if you are not inflating well, you are going to miss this lesion which is hiding behind these folds here. So in stomach, always inflate more. This is very important as endoscopists, and everyone who is doing endoscopy should know. Then the step 3 is we have to switch on the NBI, look at this demarcated area, and what we have to look? We have to look for the small tiny vessels which are known as IPCLs, intrapapillary capillary loops, and we have to see whether they are regular, whether they are irregular, whether they are dilated, whether they are tortuous, and depending on that, we can find out whether this lesion is pre-malignant or not. One more thing which we can do is spray Lugol's iodine in esophagus. Lugol's iodine will stain the normal esophageal mucosa dark, but the areas which are having cancer will be light pink. So any area you find, you can demarcate very well by Lugol's. We do not use this regularly because sometimes it causes the thickening of the mucosa and makes it difficult to resect. But this is a very sensitive method of detecting early malignancies in the esophagus. And these are the intrapapillary capillary loops. I am not going into detail what they are, but they are the tiniest branching vessels which you see on the mucosal surface, and they are appearing like this as you see on my cursor. Once you see this, this is an electron microscope figure which is showing the IPCLs as you see, and depending on them we have a classification where you can put this chart in your room, in your operating room, and you can see whether which type of IPCL you have. So 1 to 4 would be inflammation, and then IPCL 5-1, 5-2, 5-3. These are early malignancies, and you have seen here that they appear distorted, meandering, they appear irregular, and if you have this classification, you can either do an EMR or an ESD. How to choose that we will come later. Lymph node metastasis, as we have already told, that lymphatics are not present in the mucosa. They are there in the muscularis mucosa as oblique channels, and in the submucosa you can find them, as you can see in the diagram here. So any lesion invading the submucosa, you have to be wary of lymph node metastasis. And depending on this, the Japanese, who have the pioneers in ESD and EMR technique, they have classified this into if the lesion is limited to the muscularis mucosa, not invading the SM1, it is known as early cancer. Superficial is classified till it reaches the SM2 layer, and beyond that, it is an advanced cancer. So, depending on this, we will choose to do an endoscopic resection. For gastric cancers, what we see is the histologic type, the tumor diameter, whether it is ulcerated, and the depth of invasion. So, by visualization of the gastric mucosa or taking a biopsy, we will come to know whether the lesion, if you are seeing, is differentiated or undifferentiated, what is the diameter of the lesion, if it is less than 2 or more than 2, and whether it is ulcerated or not. Once you see this, we have to see three things: surface area, the color, change in light reflection. Any malignant lesion will have a very little light reflection compared to the surrounding, which is bright, and whether it bleeds on touch spontaneously. And the classification which Kanshi Yao has devised for early gastric cancer is based on three things. One is the microvascular pattern, one is the microsurface pattern, and the demarcation line. Any malignant lesion of the stomach in the early phase has to have a demarcation line. That is the first important thing. And microvascular pattern will be irregular and microsurface pattern will be irregular or absent. So if you find this, then you are suspecting a early malignant lesion. These are the examples. You can see this is regular, this area has become irregular vascular pattern, and here it is totally absent. Similarly, the surface pattern is a regular surface, irregular and absent. So these things you have to find out on white light first and then on NBI, and then decide whether this is an early malignancy. Then you can go ahead and offer the patient either ESD or surgery. For colorectal lesions, the size of the lesion is very important, less than 10, 10 to 20, 20 to 30, or more than 30 millimeters. And we classify them as laterally spreading tumor non-granulating, laterally spreading tumor granulating, intramucosal villus adenoma, or tumors with a non-lifting sign, and of course some carcinoid tumors if we find out. Any lesion less than 10, you can offer an EMR. 10 to 20, you can offer an EMR, except if the lesion is non-lifting, you have to do an ESD. 20 to 30, we would prefer to do an ESD. And any carcinoid which is infiltrating deep, you can do a surgery, but now you can also do a full thickness resection, but which is beyond the scope of today's discussion, so we are not going to do that. For colorectal polyps, we follow two classifications for classifying whether it is a hyperplastic polyp, whether it is an adenoma or a deep submucosal invasive cancer, and it is called the NICE International Colorectal Endoscopic Classification, wherein type 1 is a hyperplastic which looks similar to the background or lighter than the background. Type 2 would be darker than the background and with dark vessels, and type 3 would be irregular vessels. I will show you a few examples where you can easily make out these two lesions are of the similar background, and these are hyperplastic polyps. A dark lesion is an adenomatous polyp. Again, these are examples. You can see dark vessels here, thick brown vessels. This is an adenomatous lesion, and these are hyperplastic. So if these are hyperplastic, what would you decide? So what we do is, again, that is a little modification which the Japanese have made in the NICE 2. That is, they have classified it into JNET, or the Japanese classification, where 1 is hyperplastic, but 2 is divided into 2A and 2B, where in 2A is regular while you have some irregularity in the 2B. So this also can be used. This is a little complicated. If you use a NICE classification, it is fine. For Japanese or people who are doing ESD, it is just imperative to know a Kudo classification. This is not on NBI. This is based on spray dye, and once you spray a dye, a gentian violet, you will see the pits on the lesion, and depending on the type of pit, you can decide whether the lesion is malignant or not. So, if you see a nice one, a hyperplastic polyp, we can easily leave it alone, don't do anything. Adenomatous polyps 5 millimeter or less, we do not biopsy. What we do is just do a cold snaring. Take a small snare, remove the entire polyp and retrieve it for histopathological examination. While any polyp which is nice 3, which has an irregular pattern but superficial, less than 2, you can do an EMR, more than 2, you can remove it with an ESD. This is the Kudo classification, and you can see depending on the pits, you have the endoscopic treatment which is available for all the polyps, all the types of pits except a 5N, which is an irregular pattern, which is deep invasive cancer. And therefore, apart from this, you can offer endoscopic treatment to majority of the colonic polyps. Now, we will come to the devices, what we use and what you should have if you are planning or to do an ESD. We should have basic equipment, that is, you should have good endoscopes with an accessory water channel, where because it can bleed during ESD, and you have to have something to flush and coagulate. You have to have good cauteries, and we have 2 very good cauteries from Urbe and from Olympus, which have a mode which is called a bland cut mode, which does cutting as well as coagulation one by one, and therefore this blend cut mode is used for ESD. We have to have CO2 insufflator, which is mandatory like all laparoscopic surgeons, because this is surgery that we are doing with endoscopy, and you should not use room air that we use in diagnostic endoscopy. And so you should have carbon dioxide insufflators, preferably a low flow insufflator. There are different types of distal cap attachment, and these we are using just to prevent the mucosa from getting adherent to our endoscopy tip, and to keep the lesion at a distance so that we can have space to dissect. Not going into the details, you have 3 types of caps which are available. This is the first cap which we usually use for all our cases. It is a soft cap, and it helps for 2 things. It helps to keep the lesion at a distance, and secondly, it helps to retract the lesion, and therefore it gives you space to dissect. These are the devices now which we use. We have to have different types of knives, and this is a plethora of knife which we have. I am not going to go into the details of each knife because it is beyond the purview, but I will show you 2 knives which we use very commonly for dissection, and one is the IT knife or IT Nano. This is used for esophagus, and this is used in gastric and colon. These knives have an insulated tip, and it cuts at the bottom, as you can see here, and you can do a sideways dissection, so you can enter the lesion below at one point and come out at the other point using the coagulation current and cutting current, and you can dissect out all the lesions. The other knife is a hook type of knife which is very good for fibrosis if you have a very fibrotic lesion. And the most common knife that we use for doing all our ESDs is a dual or a dual J knife, which comes in 2 variants with a short tip and a little longer tip. This is used for esophagus and colon, and this is used for stomach. The importance of this dual is when you retract this tip back, it acts as a hemostatic forceps, so you can coagulate with this, and when it comes out, you can cut. So this is like using a bipolar instrument with coagulation and cut. This is another type of knife which is a hybrid knife from Urbe, and it has a very powerful jet function involved with this. So if any fibrotic lesions which do not raise up, you can use this type of knife which will lift up the lesion very nicely, and you can dissect out very easily. Now what we use to lift up the lesion, the basic technique of doing an ESD is any lesion you have to see, you have to inject some solution below the lesion, lift it from the underlying muscle and create a cushion. So for that we use either a 22, 23 or a 25 gauge needle, which is a simple needle, and we use a lot of solutions. Majority of the people, small lesions, we would use normal saline. If the lesion is a little bigger, we want the cushion to stay for a longer time, we would use yellow fusin, which is a viscous solution. This is nothing but a gelatin solution which is available readily with all of us. A mucoup and Ora gel. These are two things which are coming new. These are gel sort of things which will stay in the submucosa for a very long time, and you need not do repeated injections. But these are pretty expensive and not easily available in India. So we do either normal saline or gelofuscin. And plus what we do is inject a stain, either indigo carmine or methylene blue. We use 3 ml in 100 ml of saline, and once this will stain the submucosa either light blue or light green, which will separate it from the muscle underlying, and we can very easily make out that we are dissecting only the submucosa and not into the muscle. You can inject a little bit of epinephrine, 1 in 100,000 dilution, just to have a tamponade effect or a vasospasm when doing an ESD. For retraction, we do not have anything like surgeons. We do not have a triangulation effect. There is only one channel. So we use a couple of things which will help us to retract. I showed you the cap. These are two other equipments. One is a very simple thing, which is a dental floss which we use to clean the teeth. This, when you are attaching to a clip and you fix it to the lesion and you pull, you can retract the lesion. I will show you a video which will show you, and then you can dissect it below. This is another which is Zeon retraction clip, which is available nowadays, but again it is a little expensive. This is very inexpensive and can be used readily. For big defects in the duodenum, right colon, or any other, if you have by chance made a perforation, there are devices we use to close the defects. And for using, we use a loop and a clip closure. This is a small video which will show you. This is a big tumor in the stomach which we are dissecting. You are seeing that we are injecting the lesion. Once the lesion is injected, we start dissecting. You can see here, this is the submucosal bluish, the submucosal space, and gradually we are lifting the tumor out. Once the tumor is out, this was a deep infiltrating tumor, and what happened was we had a big hole in the stomach. So nothing to worry. What we do is we take a loop with the clip, fix it to the margins with several clips of the entire lesion, and once we have the loop fixed to the margins of the whole perforation, we will just tighten the loop and you have a secure closure. So this is a very important device which we use, and you can see that the tumor is there. Now we have this OTSC or the over the scope clips or padlock clips which will close the lesion full thickness. This is a small example again. This is a small, you can see this is a lesion here which we are marking and we are dissecting. This is again a big tumor which we are releasing, and we have a defect in the gastric wall. We will apply this OTSC clip, suck the defect inside, and you have a full thickness closure. So we are not worried of perforations even if they happen during our dissection. Now for the steps of ESD, as I told you, when this is the lesion, what we do is inject below the lesion, start cutting, make a circumferential incision, and dissect slowly the whole lesion out of the stomach or the esophagus. Can we have the mics muted, please, for everyone? Thank you. For any ESD, we have to do a mapping so that we know where the lesion is. So we do markings with a soft coagulation current. Once this is done, we put an incision around the lesion. It can be a circumferential incision, or if the lesions are big nowadays, we do two techniques, whether it is a creation of a pocket, like doing a poem, we going below the lesion and dissecting the lesion from below first and then from the sides. I am not going to describe all this. This is a technical example of how would you do. If this is a lesion, you use this knife, insulated knife, then you have to go distally, pull the knife and do a circumferential incision like this. If you have a knife which cuts at the tip, you have to go from proximal and just push and cut the knife, make an incision. This is again on one side and this is doing it on the other side. So this will give you an incision. Then you have to do dissection, which is very important to identify the submucosa. and the plane of dissection should be the deep submucosa, because I will show you why. This is the diagram which will show you that whenever you are dissecting in the deep, in the superficial part, you have a lot of blood vessels and it will bleed. So you don't dissect here. Go to a deeper plane, and as you can see here, in this deeper plane, just above the muscularis propria, the vessels are very less. You have a very clean field of dissection, and you can dissect out very well. So this is the plane deep submucosa where you have to dissect for an ESD. So small important tricks, how we do it: always keep the lesion on an anti-gravity side. If it is small lesions, as I told you, you can have a circumferential incision and just shave it off from the muscularis propria. Larger lesions, you go below, create pocket, pre-coagulate all vessels. Be very meticulous, don't be in a hurry. Small vessels you have to coagulate and then dissect, and use traction wherever possible. I will show you a few examples of how we resect these lesions. This is a small tumor, early gastric cancer. As you can see, we are seeing it on NBI. We found it. Now what we are doing is, we are doing these markings here. I am just running through the lesion because we have less time and I would like to show you more. Once you have this, we are dissecting. We have started putting the incision. You have to see this muscular submucosa, which is stained blue with our methylene blue, and keep on dissecting. Once you have the circumferential incision, can you see? That's a big circumferential incision we have kept. Then we go beneath the lesion and slowly with the cap we retract the lesion and peel off the lesion from the muscle bed. And this is the entire lesion which has been peeled off. You can see a big defect there. We will coagulate all the visible vessels and you have a tumor which is out, and you can take it out. This is the lesion which we remove. Okay. Next, you can have a retraction, which I was telling you. Have to understand what happens. We have here kept an incision. This is a flat lesion, so we cannot go beneath it. It was not lifting well. So what we did was, this is a dental floss, this is a clip. We have applied the clip to the margin and now we are just giving a little traction. And you see how beautifully this lifts up, and we can dissect out the whole lesion very easily. So these are a few small important tricks for dissecting. You have a defect, which if it is in the stomach, we will not close. If it is in the duodenum or the right colon, we will do a closure. Rectum, again, I will show you a small video. Maybe this is not working. This is a small important trick which we do in the duodenum, which I will show you. This is a neuroendocrine tumor of the duodenum. What we are doing is injecting, and what we do is take a circumferential incision around, dissect it, and sometimes we don't do a full dissection. What we do is, we would apply again the clip in line technique, lift up, because we don't want to injure the duodenal muscle. It is very thin. We can have a perforation, and once you have good retraction, you can remove the tumor. And we always close this duodenal defect maybe with a full thickness clip or a loop and clip method. Rectum, it's very friendly. This is the early LST which you are seeing in the rectum. We usually don't mark, but sometimes if it is very flat and we are not very sure, you can mark out the lesion, dissect out the lesion, and you can have a very good strip of the laterally spreading tumor. This is a bulky tumor, as you can see here. Again, we are dissecting. This is the submucosal plane. This is the tumor. We are using the IT knife, and slowly we dissect out, make a tunnel inside, dissect it from below, then dissect on either sides. Change the position of the patient. This tumor always has to be anti-gravity. So what we do is, we fill the colon with saline. We see where the saline pools, and we take the lesion on the opposite wall. So changing the position of the patient is very imperative, and you can have very good dissection. You can see how large a tumor we can remove. So you take use of gravity, use retraction devices, get the lesions in an anti-gravity position and dissect out all the early tumors. Now, there is a very specific method to handle the specimens that we have removed. So you have to orient, we have to tell our pathologist which is the proximal end, which is the distal end, and we have to fix it properly. And the pathologist would take serial sections at 2 millimeter intervals, and then they will also assess the lymphovascular depth, which is very important to see whether our dissection has been diagnostic or whether it has been a therapeutic dissection. The complications are there, perforation and bleeding, but we can always tackle them very easily with clips. You can see here, this is a bleeding which is happening while doing an ESD, but what we can do is spray water, apply clips and close the bleeding. If perforation is there, as you can see here, this is a lesion which we are trying to dissect, and what has happened is it has gone through. This can also be closed very easily with clips. You have to have a very clean preparation when you are doing a colonic resection, otherwise there is very high chance that the patient can get infected. En bloc resection, I am not going to go into details, but this is showing you en bloc resection rates of 70 to 90% with a very low recurrence rate using an ESD. So for esophagus, for colon and for the rectum, early malignancies, ESD is the way to go if you have a bigger lesion. EMR is the way to go if you have smaller lesions. Now, Yogesh has also tasked me to talk about EMR. So we will see. Yogesh, just let me know when the time finishes, okay? Or when I have to stop, please. Okay? Yeah, okay. I'll finish. I think I'll finish in around 5 to 10 minutes in time. So if the lesion is small, what we do is lift it and we put a snare around. Instead of dissecting with a knife, we use a snare and we dissect out. This is a simple principle of EMR. We have several techniques in EMR, that is either inject and cut, that is a freehand technique. You lift up the lesion with an instrument and cut. You do a cap assisted EMR or a band assisted EMR, and nowadays people have started doing an underwater EMR, which has still not come. Freehand is just, it works well. What you have to do is see the lesion, don't inject anything. This was done by Nip Sohendra in his old days, and I have this video from him, and you can see that in expert hands a freehand EMR works. You have just apply a snare and you remove this lesion, as you can see from here, without injecting anything. But this is not done nowadays. Lift and cut, you can use a double channel scope, lift up the lesion with one instrument and then dissect out. This is also usually not done now. Majority of the patients, gastroenterologists will do cap EMR. You can have a soft cap and use a crescent snare. And what we do is inject. I will show you a small video here that this is a crescent snare and a cap. You have to inject. Then what you have to do is put a snare inside, suck this lesion into the cap, and then with the snare you can just take out like you are doing a polypectomy. So you create the polyp out of a lesion and you snare it off. So these are the few small tricks which we do for EMR. For ligation method, what we use is multiple bands. I will show you here. This is a lesion. We are applying multiple bands, and below the band we will use a snare and cut, and we can have a very good resection specimen. The problem with EMR compared to ESD is if the lesion is bigger, as you can see here, you have to do a piecemeal resection. So you have to have multiple pieces, and there is a very high chance of recurrence. So EMR is advocated for smaller lesions. ESD can be used for larger lesions. This is a lesion, a granulation, LST granular type, which you can see here, and we are using a piecemeal EMR. You are seeing on NBI that this is an adenoma. Now what we are doing is injecting. Then we start at one margin, remove one piece, use the margin of that lesion for taking a second bite. And this video was given to me by my friend Nilay. And we do circumferential one by one, piece by piece resection from one margin to the other margin, and we can remove the entire lesion. What we do at the end of such large lesions, we will coagulate this margin with the tip of the snare, and that has shown to decrease the recurrence rates when you are doing an piecemeal EMR and not an ESD. Underwater EMR is duly developing, and you can see what happens is, the principle is, when you fill this lumen with water without giving CO2 or air, this lesion floats up and it separates from the muscle. And then without, as I showed you, you can use a freehand technique but underwater and remove this long big lesions piecemeal one using a EMR technique. So this has shown to be very less, causing less perforations and less complications, and can be used for lesions. In special situations where you have to use EMR at anorectal junction, because there are sensory fibers and EMR is preferred. Appendiceal orifice, a very small orifice, doing an ESD there is going to be very difficult, and it is very fibrotic with poor lifting, and therefore it is ideal for an EMR. Ileocecal valve, again, if it is involved in any lesion of the cecum, it is better to use an EMR than do an ESD. And small sessile serrated polyps, which are very common on the right side, and these are usually pre-malignant, they have to be removed using an EMR technique. So these are some special situations where you would use EMR and not go for an ESD. Again, EMR comes with a share of its complication, which are almost similar to the ESD, that is bleeding, perforation, but here the recurrence is a big issue. This is again a video. You are seeing an EMR which has been done, and you have just cut an artery. So what we do, inject a little bit of adrenaline, cause a tamponade, and then either you can use a coagulation or clips to be applied, and you can secure hemostasis. You can see the hemostasis has been secured. This again is showing perforation, large lesion, doing a piecemeal EMR, and what we have to see is, after you have resected, you see the specimen and see the floor. I am just running through this lesion, and you are seeing here, this is the lesion, and you are seeing the muscle which is bare with a small perforation here. So this is better closed with clips and securely. You need not close the mucosa, you have to just close the perforation which is a defect. Recurrence after EMR is a problem. It ranges from 3 to 20%. More with lesions more than 40 millimeters or 4 centimeters, as I told you. So what we have to do is application of argon plasma, which is not advocated. People have now started doing only a soft narrative coagulation at the margins, and this has reduced the recurrence. If you see a recurrence at 5 to 6 months follow-up, what you have to do is take a biopsy from the scar, treat that recurrence with a hot snare, cold aversion, or an ESD, and treat the recurrence as well. So the basic difference between ESD and EMR, ESD will give you an en bloc resection, very low recurrence, and the treatment can be curative. EMR, it saves your time, but you have to be skilled enough to see that you have a less recurrence and lower perforation rate. And both have a similar rate of preservation of the colon, so you don't have colonic resections. Similar recurrence for ESD versus EMR for non-en bloc resection, but for an ESD is preferred for lesions which are more than 40 millimeters. So EMR was developed for removing of sessile and flat neoplasms that we have discussed. Lesion confined to the superficial layers. EMR is for removal of lesions which are less than 2, or piecemeal removal of larger lesions, and ESD for lesions more than 2 centimeters. So to conclude, with the optimum patient selection, preoperative diagnosis using the technology which has been offered so brilliantly by the endoscope manufacturers, endoscopic resection offers comparable rates of curative resection as compared to surgery when the lesion is selected properly. En bloc resection is desirable to achieve optimal outcomes and optimal pathological diagnosis. So I would prefer to do an en bloc resection, whether you do it with EMR or ESD. Always aim for an en bloc resection. ESD is superior to EMR, that we have already discussed, and colorectal ESD is technically challenging as compared to other locations, and complications of ESD are slightly higher than EMR but are easily managed using colonoscope or endoscopic techniques that I have already showed you. Thank you for your kind attention, and I hope I have finished in time. And I will just stop my screen sharing and then we can have questions. Thank you.
So we would like to request Dr. K.K. Rawal, Dr. Abhishek Kakru, and Dr. Lakshmidhar to please share your experience. Dr. Rawal is also doing good number of endoscopic submucosal dissection and EMR. And we have oncologist and oncosurgeon on as a faculty. Please share your experience.
Yes, thank you, Yogesh, for this opportunity. See, there are some basic things which we all must know. These third scopy is a very time-consuming procedure. You have to be very patient and you give adequate time to pick up the lesions first. If you are doing a scopy in a hurry, there are so many lined up patients that you will miss the smaller or larger lesions even. So you have to have number one, adequate time, cool mind, and designated time for these procedures. In a busy OPD, you can't do it. Other thing, in smaller lesions, you may not take the biopsy now because that will increase the submucosal fibrosis, making the subsequent procedures EMR or ESD difficult. So either better, the best thing to learn is to convert your small, as Pankaj said, small EMR into ESD. Small polyps you can remove, inject, and do the submucosal dissection. The other problem is in these regions, we have very less number of the cases. Early cancers are hardly encountered in our day-to-day practice. So increased awareness for these lesions is also very important. And the cooperation from your surgical counterparts is also very much desired.
Dr. Kakru, you are mute, sir.
Yeah, no. So I heard the lecture. It was an excellent one. Of course, to be frank with you, we hardly see such early patients unless and until Yogesh has found one and send it to me. It's very difficult to find such early lesions in your practice as a medical oncologist. As Dr. Rawal said, we generally come across late cases. What this tells me is that you have very good technologies now to deal with such early lesions, and we should probably screening much more, which we never do in India. We generally tend to find patients who are too bad to be undergoing an EMR or ESD. If screening were to be used much more, probably you will be doing a better justice to the patient and using much more of these techniques. Why Japanese are good at this is because they have a stringent program, because they are struggling with these malignancies, GI malignancies. So that is what this tells me. Of course, I cannot comment on this because I hardly see an early patient unless and until I have screened one. So,
Dr. Abhishek, I will add, you can screen the patient who are high risk. Suppose a patient has head, neck cancer, familial cancers. These patients.
So, I'll tell you, we make it a point to ask our patients to undergo screening, but it is very difficult. Out of 10, you can convince 2. And we see a lot of patients who do screening, and you'll find a good number of patients with early lesions, and they go for this endoscopic mucosal or surgical dissection. But convincing our patients is a difficult job. You can convince an oncology patient, but you cannot convince normal patients. It is difficult to convince normal patients to undergo screening.
Yeah, but what we are seeing nowadays, the trend is that whenever you see a patient whose relative or a brother or someone in the family has a cancer and has suffered, if you tell them, I think they are now very willing to undergo a screening program. Yeah, I think that awareness is increasing probably now.
Yeah, that is increasing. Problem with screening, another problem is that if you see a patient, you ask his family members, once screening is done, screening is you repeat that at regular intervals. I don't think most patients you'll see, you will lose follow-up after maybe 1 or 2 colonoscopies. it would have never been done after, let's say you must have done 1 in 10 years or 2 in 10 years, and then you'll see you'll land up with a malignancy after 30 years. So colonoscopy means screening has to be done you have to keep the pace, you have to do it regularly. Most of these patients don't agree to that. Unless and until it is made mandatory, just like in US, you need to be screened above 50. That is where when your expertise will be much more justified. So you will have several patients. Once we start screening, you will have patients lined up for these surgeries, endoscopic surgeries.
True. There's a question for you from Dr. Smith. How do you judge the muscularis propria is involved or not by your scope? How do you choose that lesion is involving the muscularis propria or not?
Yeah. As I showed you, we always look at the pit pattern, the Kudo classification, and once looking at the pits, we can be reasonably sure to the extent of 95% whether it is a infiltrative lesion or a superficial lesion. If you have a pit pattern which is 5I or 5-4, it is always not involving the muscularis propria. If you don't have a scope which is very good, if you don't have a magnification, the simplest thing to do is inject saline with methylene blue. If that lesion lifts up, that means it is not invading the muscularis propria. That is the simplest thing which you can do. I think that it is a very practical thing. If the lesion lifts, it is fine. You can go ahead and resect it. If it doesn't lift, what you have is sometimes the lesion will not lift and only the sides will lift up. So that are the lesions which are adherent to the muscularis propria. Those lesions better not touch. This is a very simple technique which you can use.
The second question again from Dr. Smith, how do you manage the delayed bleeding after closure?
After closure of what? We close in we close lesions which are in duodenum and in the right colon. And any bleeding we manage in the same way, depending on what the patient has. If the colonic bleed is there, we would reassess that area, go in and clip it, or maybe just put in a loop and close the defect if it is there. And any other places, if it is the stomach or the duodenum, we have to treat as if we are doing bleeding in any other case of bleeding.
Do you use sprays, sort of some solutions to spray on the lesions to stop the bleeding, Hemolock or something like that?
We have not used. I usually don't use. We do a meticulous hemostasis. Nowadays, they have come out with gel in Europe and UK, but I don't think we have that available here. I think they say that it is good, but Hemolock you can obviously use, but that is not going to harm in any way. But the results probably are not too much different. So whatever is available with us, I don't think. But the gel which is available in UK and Europe, I think that is having good results, which we just discussed in a CME a couple of days ago with Dr. Pradeep.
What is your impression about removing the duodenal nets, small nets? Some people do just band ligation and remove it or leave it. How do you manage the duodenal nets, smaller nets?
Duodenal nets, we usually 1 to 2 centimeter, we will just observe, because I have seen that nothing happens to these people. So unless you have some functioning nets, unless you have some lesions which are mandatory to be removed or they are bigger, more than 2 centimeters, only those lesions we will do a resection. And I always prefer to do a hybrid resection. ESD in duodenum is very difficult and you invariably end up with a perforation because the muscle is so thin. So what we do is incise, dissect it out up to the base and then put a small snare and remove the defect, and we'll always close the mucosal defect in duodenum. That I make it mandatory, because very high chance pancreatic juice and everything coming and you can have a delayed perforation or a delayed bleed in duodenum. So we always close a duodenal defect.
How do you follow these patients after ESD?
Duodenal or any?
Rectal.
Rectal, we do a screening colonoscopy after 6 months for all the patients. And if we see a recurrent lesion, if we have done an ESD, we hardly see any recurrence. But especially those where we have done a piecemeal EMR, those patients need a meticulous follow-up at 6 months and at 1 year to see for any recurrence. And then depending on the findings, we will schedule the future screening. But at 6 months and 1 year.
Last question, how do you choose whether it's a conventional ESD or pocket or tunnel?
No, that entirely depends on the size and location of the lesion in the rectum. If you have very large lesions, more than 4 or 5 centimeters, it is always better to make a tunnel, go inside and dissect. Now, you can make multiple tunnels also. That makes your life very easy rather than doing a circumferential incision, which is very difficult in certain locations in the rectum or at the rectosigmoid junction. So the size of the lesion and the location. And we'll just keep on changing the patient's position, as I told you in my talk, just to use gravity, let the lesion fall down so that you can have a very good area for dissecting.
There's a question, how do you manage subepithelial lesions? Approach to subepithelial lesions.
Subepithelial lesions in the esophagus, usually, unless they are obstructing a very big, you don't try to remove. But if they are causing symptoms, what you have two options in esophagus: doing tunneling resection, or what we call as stir, if they are arising from the ampullaire. If they are superficial from the muscularis mucosa, you can do a ESD and remove them. But you have to have gastric lesions are the commonest that we see or come across for submucosal lesions. So for these, we will always do an EUS first, see from which layer they are arising, and then be prepared. We are not worried about even if they are arising from the ampullaire or if they are deep. But we will be very careful when we are doing dealing with the gist, as Dr. Abhishek would agree, because we would like the gist to be removed intact without injuring the capsule. That is the most imperative thing. So very large gist, more than 5 centimeters, I think it is best left for the surgeons, because we cannot remove them without injuring or touching the capsule, and there is very high risk. But smaller gists we can remove. We use the IT knife, which is very good, so it will not just surface of the gist would be touched, and we will not harm the capsule, and we will remove the intact. We always be prepared for any inadvertent or deliberate full thickness resection that we might have to do, because these are arising from the ampullaire, and we would close them as I showed you using either the loop and clip. If they are small, you can use the over the scope clip. And now, of course, we have access to suturing devices also, which I have not touched upon because it is not very commonly used now, but we have suturing now. So probably big defects we can suture also if we have to go full
But
thickness.
don't you think that EU has many times understays or overstays the depth of the lesion?
I agree. I agree. I agree.
Can I
Absolutely.
ask for
And
that?
yes, yes, yes.
Yeah, the gray area, I think, for being surgical oncologist for the endoscopist is the SM1. If I correct me if I'm wrong. And Dr. Pankaj, your experience is quite good about the endoscopic resection. So how do my question for the such type of lesions which are between like T1A and T1B SM1 kind of, So what is your preoperative workup and how much effective is it? That is one thing, because many time we do fallacy here. And second is when you end up with close margin somewhere, and you feel that it's however R0, it may not be R0, but it is
Agree.
microscopic residual disease there. So what is your take home for the rest of the audience? And third, in particularly SM1 lesions, how do you follow these patients?
See, usually this happens when you are dealing with gastric or esophageal. Colon, I think things are very
Yes,
simple. Colon,
particularly
you
esophageal, more so in a
yes,
lower esophageal.
yeah. So the we have only the chromoendoscopy, that is the digital chromoendoscopy for judging the depth of the lesion. EUS, unless we have a mini probe, it is useless. We would not do EUS because it will never assess the depth of the lesion. So what we follow is whenever we see an early lesion on NBI, and maybe if it is resectable, what we do is we would do a diagnostic resection.
Mhm.
So we will remove the whole lesion, we will mark the proximal and the distal end, and we have a pathologist who is trained and they will tell us the lymphovascular invasion and
Mhm.
which layer it is. If we have a depth of invasion which is less than 200 microns in the esophagus, we are fine. But if our pathologist tells that there is some doubt or the margins, there is any residual disease, we would treat these lesions as malignant lesions and probably offer them what you would offer, either a surgical resection or maybe neoadjuvant chemo or radiotherapy. We will not leave these lesions untouched. That is very important. So we always measure the depth of lymphovascular invasion, and our pathologists have to be trained. They have to tell you what is the depth. And once you see that, you can either observe, or if there is any doubt, any semblance of a doubt, the patient goes for an oncologic resection.
I think that is the staging ESD for this.
Yes, that you can call it as a staging
Yeah.
ESD.
So basically, it's staging ESD, true. Mhm.
Yes. Because
And
there is no way to be sure with EUS or any other modality which layer it is. It will give you almost a good estimate up to the tune of 90-95%, but beyond that 100% is impossible unless you resect the whole thing out.
so I think I will agree with my fellow colleague, Dr. Abhishek, that the number of cases we see or we encounter during our practice is very less. So
Right.
even being oncologist, our experience is very limited, and what to do and what to say our patient is a big problem. Now, in one of the patient, we face the same issue, and I think whenever endoscopist is also in a dicey condition or situation, when first is when his or her pathologist is not that sound. I mean, not that sound, not in the sense of knowledge or something like experience, but he is not clear about whether the depth is
True.
this or not. And second is when endoscopist himself thinks that the tumor is little aggressive, then however he has removed it in toto, but clinically it looks aggressive. So in this patient, at the end, endoscopist only told us that better you go for the curative surgery.
I think that
I
that is
mean,
always we have to always accept the limitations that we have,
true,
and in the
true.
best interest of the patient. So we never try to be so, oh, nothing is going to happen. We will not have no. That is you may fall flat on your face. So you have to have the patient's faith, whatever technique or technology you have, but always have the patient's faith in your mind and
But I
ability.
think oncologists have a bigger role in sending the patient for screening. Their relatives, they will be more convinced by you rather than the endoscopy.
True, actually. But still, Abhishek is right that to convince the people, particularly in Indian population, for esophageal and colonic, still patient are ready. But for esophageal and stomach, screening seems and to convince
Yeah.
the patient is a little difficult. Now, third question, and the third thing is, how will you follow up the patients with T1A tumor, biopsy proved, and you have removed it with good margin and good depth? What will you do to them, particularly for the upper GI?
Yeah, upper GI, I think we follow a similar. We do a screening scopy at 3 months, then at 6 months and 1 year. And then depending on we will do the screening. If there is no recurrence, we will just observe the patient. Otherwise, but we do a screening scopy at 3 months, then at 6 months, and then probably at a year.
Good. Thank you.
So, Dr. Pankaj bhai, just taking from where Dr. Murtaza was saying, so there is no provision, or there must be somebody who has thought of like the surgical oncologist who are frozen during your procedure and revision of the endoscopic resection. If you find that you have not been able
Margins are
to get
inadequate.
clear margins, or
Right.
you have not been able to remove the entire thing as you desired.
I think Abhishek, that's not possible here in ESD. If I correct me, Dr. Pankaj bhai.
I agree. It is not possible. Once you have done, if it is at another location, it is okay. But you for the same lesion or the residual margin, it is impossible.
So somebody must have thought about this. Na? They must be doing something about it somewhere in the world.
For once you have resected the lesion and if the margins, I think the other option would straight away come would be either surgery or neoadjuvant. I
So
don't
that
think.
means every procedure you would have to go in explaining the patient that you might probably need a surgery if I'm
Yes,
not able to do this.
definitely. We always tell all the patients that what we are attempting is probably going to save you a esophagectomy.
In that process, we lose the patient also to you.
Yeah,
Yeah,
no.
so
So
we have our surgeons involved in whenever we do this decision making. It is always to be a combined decision, and the patient has to understand that if we have a curative resection, it is for his benefit, and we are saving a major surgery which definitely carries morbidity. So that understanding has to be created. Otherwise, it is always safer not to do these procedures. Because if there is a recurrence and the patient doesn't come for follow up, you are gone.
Thank you, Dr. Pankaj bhai. Dr. KK Rawal, it's new introduction for me. Thank you, Yogesh. I may leave a little early if you permit me.
Sure.
Yeah, I think it's already 9:30, but we can always stop. Thank you, sir.
Thank you.
So, Dr. KK Rawal, if you allow, can we close the session for today?
Sure.
Yes, okay.
So I thank Dr. Abhishek Kakru, Dr. K.K. Rawal, and Dr. Lakshmidhar for being here, and Dr. Pankaj Desai. It was a very lucid talk and very basic talk. Thank you so much for accepting our invitation and educating our physicians and such. Thank you.
Okay.
Thank you, everyone.
Thank you.
Thank
Thank
you,
you,
Yogesh.
Yogesh.
Thank you,
Bye,
Pankaj bhai,
Doctor.
Rahul bhai.
Bye, Dr.
Good night.
Abhishek.
Good night.
Good night, Dr. Rawal.
Good night, Pankaj
Bye.
and Yogesh.
Bye.